behalf of Health for the World, good morning to everyone that has joined for today's radiology grant rounds titled Stroke Emergent Large Vessel Occlusion Imaging and Interventions. And our guest speaker today is Dr. Mahesh Jayaraman. Dr. Mahesh is an associate professor of diagnostic imaging, urology, and neurosurgery at Brown University. Dr. Jayaraman completed his medical degree and radiology residency at Brown University in Rhode Island, and then continued his fellowship training residency in diagnostic and neurointerventional radiology at Stanford in California. Dr. Jayaraman also serves as the director of Neurovascular Center and is an active member of many societies, including the American Society of Neuroradiology and Society of Neurointerventional Surgery. Dr. Mahesh is an active researcher and has published over 90 peer-reviewed articles. Dr. Mahesh, thank you so much for being here today. We are very excited to hear your lecture. Please continue.
Thank you. Hopefully you can all hear me well. I apologize if sometimes I look up. I have dual monitor set up and I have the chat open and I'm seeing where some of the participants are coming from. And I'm seeing Nigeria, Rwanda, Cape Town, Zambia. Sounds wonderful. All places I would love to visit one day. So I don't have any disclosures and I'm just going to jump right in. If you have any questions, please ask them in the chat and we can address them at the end. So very basic terms. When I talk about stroke, what are we talking about? What is a stroke? Well, about 85% are ischemic, and that is a blockage of blood flow to the brain. And about 15% are hemorrhagic, and that's bleeding into the brain. And stroke imaging, we're trying to answer basically two questions. Is the patient having a stroke? And if so, what type of stroke? So the first question we need to know is there blood in the brain? Is there hemorrhage in the brain? This is very easily done with non-contrast CAT scan. And this is the first step. And acute hemorrhage is more dense than gray matter. And this is because of the iron content. And so these are all just simple examples of a thalamic hemorrhage, a lobar hemorrhage, another lobar hemorrhage, another more lobar type hemorrhage, but they're all the same. The acute hemorrhage is hyperdense on CAT scan. So non-contrast CT, superb at identifying these areas of hemorrhage. The next thing we want to know is, has there been a large area of completed stroke? In other words, tissue that has already infarcted. So when we think about this, what happens in a stroke, right? So once the cortex has infarcted, the cells in that cortex, they lose the ability to maintain membrane integrity and they swell with water. And so the result is a loss of the normal difference between the density between gray matter and white matter. So if you will, imagine in this coronal cross-sectional schematic image, if there was a stroke in an area, you would lose that differentiation and the cortex would become the same density as white matter in the acute setting. So here are some examples on multiple axial images from a non-contrast CAT scan. And what you can see is there's increased water in the cortex from cell death, and there's loss of the normal differentiation between gray and white matter. Everything looks very homogeneous and hypodense compared to the normal cortex on the other side. We will want to be more precise and systematic in quantifying how much infarct there actually is, but we'll get to that later. The next thing is we want to know is there a mass? Is there a tumor? And there we're looking for vasogenic edema, right? So this is the white matter, which starts out hypodense, becomes more hypodense. And typically vasogenic edema is going to spare the cortex. So now you have the opposite. You have accentuated the gray and white matter differentiation as opposed to obscuring it. And this is typically associated with some mass effect. So now if you can imagine, this distinction between cortex and white matter becomes more evident because of an underlying lesion. So here's an example. This is a patient who had a metastatic lesion in the left frontal lobe, And now the increased water in that cortex has resulted not in a loss of the gray and white matter differentiation, but an accentuation of it. The white matter is more hypodense. This is vasogenic edema. So great, this is wonderful. You've excluded hemorrhage, you've excluded a big completed stroke, and you've excluded a large tumor. So that's enough to determine if a patient is a candidate for intravenous thrombolysis. But let's rethink this concept, right? So we said it's not a hemorrhage, it's not a completed stroke, and it's not a tumor. So it's something else. So then the question really is, what is something else, right? And historically, what we have done is once a patient has ruled out, we treated them with TPA by exclusion. And so I'm sure some of you remember these cell phones from the 1980s and 1990s. This was great. This is what computers looked like in the 90s. But we've moved, we've evolved. And if we're sitting here just doing non-contrast CAT scans alone in 2022, that means we have not evolved in our approach to stroke imaging. And so what is something else? Well, it could be a mimic, true. Could be migraine, seizure, a metabolic derangement, all possible. But the biggest thing we're worried about is that this is an acute cerebral ischemia. And this could be with or without a large vessel occlusion. And there are a variety of different etiologies. This could be cardioembolic, it could be atherosclerotic disease, could be a dissection. And for too long, we have used imaging to view the sequelae, the end product of a neurovascular event, rather than looking at the primary problem, the primary issue. And if you think about it, a stroke is an acute vascular syndrome. And everywhere else in the body, acute vascular syndromes result in acute vascular imaging. So pulmonary embolism, we do a CAT scan to look at the pulmonary arteries. Aortic dissection, traumatic injuries to the carotid or vertebral arteries, acute lower extremity ischemia. So all of these are acute vascular syndromes, and they're all imaged with acute vascular imaging. And what that means is every single stroke requires acute vascular imaging. And acute stroke syndromes are a vascular problem, and vessel imaging at presentation allows for detection of ELVO and for a possible etiology. And the good news is in 2022, we can get this answer in less than a minute in the scanner. So a modern approach, yes, we have to look for blood. Yes, we have to look for a big completed stroke. But the next thing we need to know about is what is the status of the blood vessels? And the first and most important question we have to answer is there a blood clot? So defining large vessel occlusion. Generally speaking, we think of ELVO or large vessel occlusion in the anterior circulation involving the ICA, either the total ICA or just at the terminus, the M1 segment of the middle cerebral artery, M2 segments proximally of the middle cerebral arteries, and then in the posterior circulation, the vertebral and basilar systems. It's very important to understand that a clinical exam cutoff will miss large vessel occlusion. This was a nice paper that's older, but it very nicely shows even with an NIH stroke scale of 1 or 2, these are minor symptoms, up to 10 to 20% of occlusion cases can be missed. Here's another one that was a larger paper that looked at this and basically says that if you have patients, it's a 1,000 patient cohort with a median stroke scale of 7. So those are moderate symptoms. A third of these patients had an occlusion of the ICA, the M1, or the basilar. So these are big, important vessels. And their conclusion was that it calls into the usefulness of clinical scores to identify large vessel occlusion and suggests that MRA or CTA should be performed in all patients with symptomatic stroke. And I agree, that's very important. And it's important to think about large vessel occlusion as a brain attack. And historically, this had a dismal prognosis. So historically, large vessel occlusion used to leave 3 out of 4 patients disabled or dead at 90 days. Only 1 patient would be independent at 90 days. But we can fix this. And the concept was so simple. That is, that restoration of blood flow to ischemic tissue before permanent damage should improve outcomes. So this is Health for the World. This is a beautiful city that I would love to visit one day. This is Istanbul. And one of the most important things that happened in stroke care was in October 2014 at the World Stroke Conference. And that is Mr. Clean trial, which was done by the Dutch in the Netherlands, was the first positive trial of endovascular stroke therapy. There were, at that time, 4 other trials that were ongoing: ESCAPE, SWIFT Prime, Revascat, and Extend IA. And they actually halted their enrollment. This is another beautiful city that I've had the pleasure of visiting, and I hope people come to as well. This is Nashville, Tennessee, here in the US. And this was in February 2015. And for those of you who've gone to medical meetings, I will tell you that this felt more like a rock concert than a medical meeting, because it was standing room only to get in to hear these trial results. And when they were announced, people got up and gave a standing ovation. But the ESCAPE trial, SWIFT Prime, and Extend IA all showed their results, positive trial results. And if we look at these trial results, whether we pick from Revascat, Mr. Clean, SWIFT Prime, ESCAPE, or Extend IA, they all showed a dramatic improvement in clinical outcome with endovascular therapy, so thrombectomy, compared with best medical therapy alone. The number needed to treat, right? So the higher the treatment effect, the lower the number needed to treat. The number needed to treat, to have one more patient be independent at 90 days, was as low as 3 and no higher than 7. That is dramatic, okay? And for those of you who want a comparison, in many parts of the world now, if we can get access to primary PCI for patients with myocardial infarction, that is considered far superior. But the number needed to treat for that is not 4, and it's not 8, and it's not 12, it's 17. So the treatment effect of thrombectomy for stroke is at least 3 to 4 times more powerful than the treatment effect of primary PCI for myocardial infarction. The number needed to treat for any improvement in outcome is a sort of a shift. It's about 2.6. This is the most powerful treatment effect of any procedure we can imagine in medicine. So we went in 7-month period from no benefit based on older technology and older patient selection to standard of care. And that's never happened before in medicine that quickly. A couple of things to note about these 2015 trials of thrombectomy. So recanalization matters. So the IMS-3 trial was a negative trial. It showed that endovascular treatment was no better than medical treatment alone. But if you look at it, the recanalization rate in that trial was only 44%. So you're putting patients through, you're randomizing, but you're actually only successful half the time. Mr. Clean and Revascat had slightly higher rates of recanalization, and therefore they had a positive trial, but the absolute differences were lower. And ESCAPE, Extend IA, and SWIFT Prime had even higher rates of recanalization. And you can see very nicely that as the likelihood of achieving near complete recanalization increased, the likelihood of a good outcome increased. The other factor is time. So if we look at how long the procedures took, in IMS-3, the median time was 121 minutes, 2 hours. So it took 2 hours, and they only opened the vessel 44% of the time. That's a recipe for a negative trial. In Revascat and Mr. Clean, the procedure times were shorter and had absolute differences of 16% and 12%. And again, SWIFT Prime, Extend IA, and ESCAPE, much faster procedure times, higher absolute differences. If we think about the factors in the treatment decision, we think about time from symptom onset or last known normal. What is the extent of the clinical deficit that the patient is having? Where is the clot? And how much baseline infarct do they have prior to treatment? And the 2015 trials really focused on this small sweet spot of patients in the first 6 hours who had moderate to severe clinical deficits with small or moderate infarcts and ICA or M1 occlusions. Time matters. So I've shown that the Revascat and Mr. Clean trials had lower absolute differences than the other three. They also treated patients later. So the median time from onset to recanalization was longer in Revascat and Mr. Clean than in the other three trials. But every single patient is different. And here are a couple of different series, one from the Diffuse 2 study and one from an MGH series of patients with known ICA and M1 occlusions. And what you see is in the red are patients who have big stroke early. And this is unfortunate. We call these patients fast growers or exponential growers. But in the green, there are patients who have a small stroke beyond 6 hours, right? And what the point here is that an arbitrary time cutoff is a population average. So why not individualize to the patient? Why not use imaging to determine if somebody who's in this green can actually benefit from thrombectomy? And that was how the Dawn and Diffuse 3 trials were structured. They both looked at patients with ICA and M1 occlusions who had severe strokes and were treated up to 24 hours from symptom onset. The imaging paradigm was slightly different. In Dawn, the imaging paradigm was between the infarct core and clinical deficit. In other words, somebody had very small amount of stroke on imaging, had a big clinical deficit. Diffuse 3 focused on a mismatch between the infarct and hypoperfused tissue. Didn't matter. Pick whichever one you want. A dramatic benefit to thrombectomy. And in fact, if we look at time from symptom onset to treatment, the early window trials, most of these patients were treated in the first 6 hours. The median time in Dawn and Diffuse 3 was 12 hours. So if we take a look at this previous graph that we had looked at time and outcome, and now we throw in Dawn and Diffuse 3, what we notice is all of a sudden, things don't seem to match, right? And so you're all probably asking, well, wait a minute, what happened? I thought you told me that time was important. And time is important, but I want to, again, focus on the importance of imaging in these patients. And this is adapted from a nice editorial from Michael Hill from the Calgary Stroke Program. And what this looks at is thinking of it from the first epoch of time is the time from symptom onset or stroke onset to when the scan is done. And the second epoch is from imaging to vessel open. If you look at the first epoch of time, what you have is a decay in patients having favorable imaging. And so the time from onset to imaging is defining the likelihood that you have a small infarct on arrival. So these early window trials, these 2015 trials, focused on a larger group of patients because most patients have eligibility early on. The late window trials, this is the slow progressor. In contrast, the likelihood of a good outcome, once you've done the imaging, you can almost reset the clock and say, how quickly can you go from favorable scan to vessel open? And that's what's going to determine the likelihood of a good outcome. How quickly you go from favorable imaging to reperfusion. And if you think of an entire population, and this concept of eligibility decay nicely shown by Dr. Goyle in this editorial in 2017, the 3 to 6 hour window, most of the population is eligible. And so there is a dramatic treatment benefit. In the greater than 6 hour time window, a lot of patients are ineligible, but these patients do benefit dramatically. The real key and the challenge throughout the world, especially in some of the nations that are in the developing world, is the patients in the time less than 2 hours. The effect of endovascular therapy for stroke is dramatically time dependent. And it's even been quantified in this beautiful paper down to the effect of what a minute does. And it turns out that if you look at it based on an age strata and stroke scale severity strata, the bottom line is that for every minute faster 1 week of disability-free life is gained. And for younger patients with severe stroke, it's closer to 10 days. So if you can save an hour, you're essentially giving a patient back a year of disability-free life. Naturally, you can imagine that this is also cost-effective. And this was a very nice analysis that was looked at this and presented at the ESO meeting. And based on US healthcare dollars, every minute faster saves $1,000. And that's even more earlier in the time window. Now, the procedures are challenging enough, but we have some time pressure within the procedure. And this analysis looked at how long it takes the case versus good outcome. And what's really interesting is after about 30 minutes, the likelihood of a good outcome drops substantially. It's still better than if we do medical therapy alone, but the bottom line is you really want to try to reperfuse patients within the first 30 minutes of the procedure. So to summarize thrombectomy for stroke as a procedural analysis, it dramatically improves outcomes. We need fast and complete recanalization. Every minute faster gives the patient a week of disability-free life, and every minute faster saves the healthcare system $1,000. So this is a unique problem in medicine, and we have lots of marginally effective therapies that we give lots of patients, but we have an unbelievably effective therapy that patients don't get. We have the cure, but patients don't get it. And why is that? It's because we're too slow. So if we look at all of these symptoms, stroke recognition to hospital arrival to imaging, imaging to treatment decision to vessel open, I'm going to focus on this presentation on imaging and how we use the imaging to help us make a treatment decision. But please keep in mind, this is one aspect of the entire system of care for a patient. In many situations, the part of stroke recognition to hospital arrival is a much bigger challenge. Daniel and I were speaking about this. There are many parts of Central and South America, Africa, Asia, where this is a much bigger challenge than in Western Europe and in the United States and parts of Canada, where patients have a more robust system of recognition to hospital arrival. But for the purposes of this study, let's talk about this second part. So there's lots of different things we can do with imaging. This is the bottom line on my bias, and I'll get to why it is. I think that non-contrast CT and CTA is more than enough to triage patients in the vast majority of cases. Go from there to the angiography. So we talked about what we need to know, right? Now we found that blood clot. And beyond that blood clot, the tissue is hypoperfused. And we're going to talk about a few different terms here, right? So the first is the infarct poor or baseline infarct. The concept here is this is pretty much dead brain, right? So this is infarcted brain that you're probably not going to be able to salvage. The next area is this tissue concept of penumbra. And so the brain penumbra is tissue that is at risk for infarction. It is currently salvageable, but does not have enough blood flow to maintain its electrical function. So the neurons are not firing, the cortex is not working, but it is not infarcted. It has not lost membrane integrity yet. Beyond that are some areas of oligemic tissue. They're not quite getting as much blood flow as they need, but they are able to function. So how do we find the clot? Simple, CTA. It's quick, it's accurate, it's remarkably good at finding the clot. So now let's talk about the core. And we can identify the infarct core using a variety of different techniques. We can look at non-con CT. We can use absence of collateral filling on CTA. For those people that want to use CT perfusion, the currently accepted threshold is about a reduction in relative cerebral blood flow to 30% or less of the normal. And on MRI, diffusion weighted imaging, you're looking for ADC values less than 620. So what is ASPECTS? ASPECTS is it stands for the Alberta Stroke Program Early CT Score. It was developed in Calgary, and it gives a quantified degree of the early ischemic change in the MCA territory. We divide the MCA territory into 3 deep regions, the caudate, the internal capsule, and the lentiform nucleus, and 7 cortical regions, M1, 2, and 3, the insular ribbon, M4, 5, and 6. In any area that is abnormal with early ischemic changes, not chronic changes, early ischemic changes, we subtract a point. So patient starts at 10 is normal, and we subtract points as we go and go down to as low as a 0. What's very interesting is the Hermes analysis. So Hermes took the 5 2015 trials, took pooled patient level data, is that you could pick an aspects of 10, or you could pick an aspects of 6, and the odds ratio for treatment is pretty similar. So there's a benefit of treatment across the spectrum. If you trichotomize these, you can actually see that endovascular therapy even improves outcomes in patients with an aspects of 3 to 5. And it's a similar odds ratio as those in the 6 to 10 strata. So what does that mean? It means that given the degree of improvement in outcome, the treatment effect is so profound that there's not a need to precisely differentiate aspects 5 versus 7 or 6 versus 8. In fact, if you look at the inter-rater reliability of aspects, most expert readers will often differ by a point. Okay, what about the CTA collateral score? This is simple. It looks at how many of the vessels beyond the occlusion are still seen. The best way to evaluate this is using a thick slab MIP reconstruction, because you really want to look at the forest, not the individual tree. So here's an example of good collaterals. This is a patient with a distal right M1 occlusion that you can see with the arrow. And you can see that the vessels beyond that territory are still patent and fairly symmetric compared with the contralateral side. In contrast, here's a patient with poor collaterals. This patient also has an M1 occlusion. But what you see, especially on the second and third images, is there is poor contrast opacification of the area beyond the occlusion. There's a large area of asymmetry. In fact, if we look at the Mr. Clean trial data on poor collaterals, the 0 and 1s, these are patients with absent or poor collaterals, had really no definite benefit to thrombectomy. But the grade 2 and 3 collateral patients had a significant benefit to intraarterial therapy with thrombectomy. We can take this one step further using a technique that was developed by Dr. Mayank Goyal and colleagues of multi-phase CTA. And here we do 2 additional phases through the brain. So we take a arterial phase image, a peak venous, and a delayed venous phase image through the brain. And the idea is that this can potentially help us differentiate. So here's an example of 2 different patients, right? So the first, they're both 60-ish-year-old male patients early in time from symptom onset. I'm showing you representative images from the arterial, peak venous, and delayed venous images. Now, if we look at the top patient, there's minimal filling of these MCA branches beyond this right MCA occlusion on delayed imaging. And in contrast, the bottom patient actually has filling of that patient, okay? That territory, rather. If we take the top patient and we obtain a hyperacute MRI, basically looking at diffusion-weighted imaging, what we see is that there is a large area of infarction. Almost the entire right MCA territory is infarcted. This is just 2 hours from symptom onset, but this is a patient who's a fast grower. Remember, every patient is different. The bottom patient we actually took for thrombectomy, we recanalized, and the next day has essentially no infarct. So this is my viewpoint. I admit it, biased, but that the combination of non-contrast CT and CTA, if you have good aspects and you have good collaterals, you have a small baseline infarct, and that the additional value of CT perfusion and MR is minimal. It's important to realize that one of the problems with CT perfusion is that the definition of core has changed over the last 20 years or so that I've been in this field. The definition of core on CT perfusion has changed multiple times, and it's especially unreliable early in the time frame. So I'm going to show this example. This is from Mark Rebo and the group in Spain, and what they showed is that the CT perfusion on this patient at admission says it's a large core, matched defect, low CBF, low CBV. Don't do endovascular therapy. But they did it anyway. And the CT at 24 hours shows minimal stroke in the basal ganglia and a dramatic improvement in the patient's clinical outcome. In the Hermes data set, again, they looked at CT perfusion, ischemic core volumes, and compared it to outcome. So here is the core volume on the x-axis. The y-axis is independence at 90 days. And what you'll notice is that every single ischemic core volume, the thrombectomy group did better than the medical therapy group, right? And so the CT perfusion derived measurements may help with prognostication, but probably not with treatment decision, an important concept. What about MRI? So this is from the Burn group based on diffusion weighted imaging, looking at patients who were recanalized versus not. And the outcomes were better with recanalization than not, excuse me, at all DWI sizes. Now, what about diffusion lesion? Again, same thing, may help with prognostication, but not as much with a treatment decision. Okay, what about beyond 6 hours? Didn't the trial show that we need CT perfusion and MRI to show us the infarct core? Well, a couple of groups have looked at this. We looked at this in our data set, and what we found is if you have favorable aspects and a favorable collateral score on multi-phase CTA, you have a small DWI lesion. And if you have either a poor aspect score, 0 to 4, or a poor collateral score, you have a large DWI lesion. And this is also shown very nicely in this paper in Stroke in 2019. Bottom line, poor collaterals on multi-phase CTA shows you that you have a large DWI lesion. Okay, so we've talked about this modern approach. We've identified that there's no blood. We've seen that there's no big completed stroke. We've found the clot. We've quantified the core. Now let's talk about the penumbra. The concept of mismatch can be done using either clinical or imaging. On the imaging side, when we talk about mismatch, we're talking about is a mismatch between the blood flow to the penumbral tissue, and that's typically done using a Tmax value greater than 6 seconds, and the core. Again, we've talked about core aspects, collaterals, cerebral blood flow on CTP or DWI MR. You can also do this clinically. Remember that the patient's clinical deficit comes from the combination of core and penumbra. So if a patient has a big clinical deficit and a small core by imaging, then by definition, you have to have penumbra. Okay. This is an older paper from our group, but one that's relevant, and it's actually more relevant now. We actually published this before any of the thrombectomy trials were positive. But basically, we had 4 neuroradiologists, 2 evaluating patients with the combination of non-con CT, CTA, and clinical deficit. So I had the imaging, I had the clinical deficit, and then the other group had the perfusion maps, had CT perfusion maps. And the goal was to identify, is there a patient who is eligible for thrombectomy? And there's no difference in treatment decision. So you can choose based on CT, CTA, and deficit, or CT, CTA, and perfusion. There's no different in the treatment decision. Interestingly enough, in the Mr. Clean trial, so we showed how the collateral score modified the treatment effect in Mr. Clean. But in the Mr. Clean trial, there was a benefit to thrombectomy regardless of the presence or absence of imaging mismatch on CT perfusion. So mismatch, no mismatch, still treat. In the Dawn sub-analysis, what was interesting was if you have good and fair aspects, all these patients have imaging mismatch according to the Dawn criteria, which is very strict for a small core. And none of these patients up to 24 hours with an aspect 0 to 5 would have met Dawn clinical core mismatch. So if you have a excellent aspects or even a good aspects, you're going to meet the Dawn criteria. Again, do you need a CT perfusion or MR perfusion to tell you there's a mismatch? And in fact, if we look at the imaging mismatch and the trials, we have 2 early window trials here and 2 late window trials. The early window trials showed a dramatic benefit, and these two late window trials showed a dramatic benefit. And which ones were imaging based and which ones were clinical core based? Well, SWIFT Prime was an imaging based mismatch, and ESCAPE was a clinical core implied mismatch. Same thing with Dawn and Diffuse 3. There's a treatment effect no matter which of these paradigms you choose. Choosing a clinical core mismatch is simpler and easier. And so I really do think that the additional benefit of imaging based on mismatch above and beyond a clinical core mismatch in real world situations is unknown. Now, it's very tempting to fall for this. We see this all the time, right? See so many papers that have said patients selected using blank instead of non-con CT and CTA had better outcomes. And then I've seen this also published. We have the highest rates of independence at 90 days because we're very strict with our imaging criteria. Well, that's great. And who do you really want to be, right? So every one of us, I want to have an 80% good outcome. I would be okay at 60%. I don't know if I really want to admit that I only have a 40% good outcome rate. But how do you get there? You get there based on how selective you are. So the people that tell you they have an 80% good outcome rate with thrombectomy are highly selective. And those that are 40% good outcome are probably the least selective. And the reason for that is who are they excluding based on imaging criteria? So those centers that are 80% good outcome, they're not really at 80%. What are they at? They're at 28%. Why? Because they excluded all those patients, didn't give them a chance, never treated them. And the 60% good outcome is closer to 33% on a population level. And the 40% good outcome is actually probably the best because they took almost every comer and they didn't exclude as many patients. Okay. And this, I think, is the danger of over selection. I think you are more likely to cause harm by overly strict imaging criteria and excluding patients from treatment, as opposed to being more liberal and trying to offer treatment to more patients. That's my personal bias. So I think that, we have something that's really dramatic and effective. I don't think it needs to be more complicated than it has to be. I think that the combination of non-con CT and CTA can quickly and easily identify ELVO patients who are candidates up to 24 hours from symptom onset. And I think that any additional imaging beyond that is simply just taking up time without necessarily helping more patients. And the big part of this is, additional information from CT perfusion or MR can be very helpful for prognostication, but prognostication is not the same as helping you make a treatment decision. So I'd like to thank everyone for joining. Again, I'm seeing lots of people from many, many parts of the world. If you have questions, please enter them in the chat. I'd like to wrap up with a few simple points. Number one, thrombectomy for stroke is the most effective procedural therapy in medicine. Simple. Every minute saved saves $1,000 to the healthcare system and gives patients a week of independent life. Non-con CT and CTA need to be done on every suspected stroke patient, regardless of severity. There are no severity score cutoffs that should be used to not obtain acute vessel imaging. And additional imaging beyond those two may add delay without necessarily improving outcomes across a population. So with that, I'm going to stop sharing. I'll say thank you to everyone and open up for any questions.
Thank you so much, Dr. Jayaraman, for this wonderful lecture. It was the graphs, how you portrayed the information was very clear. Thank you so much. We don't have any questions right now. Okay, questions.
I see a couple, yep.
Yeah, so the first one comes from Dr. Mpateni.
Yes, and so is there any role for intraarterial thrombolysis? So that's a really good question. So in the IMS-3 trial, the IMS-3 trial actually had 3 arms. It had a medical therapy arm, it had an intraarterial thrombolysis arm, and a thrombectomy arm. The intraarterial thrombolysis arm in the IMS-3 trial, patients got 20 milligrams of intravenous alteplase administered over 2 hours at a rate of 10 milligrams per hour. At the current rate, I think that it takes far too long for intra-arterial thrombolysis to work for proximal large vessel occlusion. There may be a role for intra-arterial thrombolytics to help clean up distal occlusions. There was a trial that was presented recently at the International Stroke Conference in a small cohort of patients that suggested that intra-arterial thrombolytics given after thrombectomy may improve outcomes. So there may be a role for administering a small amount of intra-arterial thrombolytic after thrombectomy for the proximal occlusion, but generally speaking, not as the primary treatment for large vessel occlusion.
Okay, thank you so much. We are getting some thank you.
There's another question in the Q&A that is between MRI and CT, which is best for diagnosis of stroke? So there's no question that MRI is more sensitive. Okay, there is no question. MRI is the better exam. However, in the very acute setting, what you really need to know more than is there a small stroke on the diffusion weighted imaging is what is the vessel status. You need to know the vessel status more acutely than you need to know whether or not there's a small stroke on MRI. And so I think the answer is yes, MRI is better, but in the acute stroke evaluation, the workhorse there is CT and CTA. If you work at some of the academic medical centers that have immediate access to MRI, we do that. I know that the Mass General, where Daniel is, also has immediate access to MRI. We don't do that as the primary modality. We start with CT and CTA, even though we have immediate access to MRI.
Right, thank you. There's another one, another question that says, based on aspect score alone, patient presented after 6 hours, why thrombolysis
not to be considered? Okay, so that's an excellent question. And I presume that this is referring to intravenous thrombolysis beyond 6 hours, or actually 4.5 hours is the cutoff. And the answer to that is that there have been a couple of trials that have demonstrated a benefit to extended window thrombolysis, the Wake Up trial being one of them. And both of those trials used MR-based selection. And so we do have a clinical pathway here at Brown where patients who are beyond 4.5 hours, who have a wake-up stroke, and I'm sure, Daniel, you probably have something similar at MGH as well, are evaluated with a hyperacute MR. And the paradigm in the wake-up trial was a DWI flare mismatch using regions of interest, comparing the DWI signal abnormality and the flare signal. You can also do this using perfusion-based selection for more distal occlusions. The reason that it does not, that we don't do it beyond 6 hours is based on earlier data, pooled data such as ECAS-3, intravenous thrombolysis beyond 4.5 hours was associated with higher risks of hemorrhage without improving clinical outcomes.
Thank you. Yes, we actually published a paper about 2 years ago with hyperacute MRIs. And what we were trying to see was what was the correlation between MRI using like susceptibility weighted sequences to detect thrombus. And it's actually pretty good, but only in the proximal segments. The most distal segments, you're going to lose them. There's another question from Dr. Mpateni. How steep is the
learning curve in training to perform thrombectomy safely? Unfortunately, the training curve is pretty steep. You saw that the cases have to be done very, very quickly. In order to become facile, to be able to safely place a catheter in someone's middle cerebral artery in 10 minutes, that takes a lot of experience. In an ideal world, everybody that does thrombectomy is a neurointerventionalist with full neurointerventional training. There have been those who have advocated that in certain geographic areas, other vascular specialties should pick up the mantle. My concern with that is that the message then becomes thrombectomy can be done by anyone, and even in areas that have access to trained neurovascular neurointerventionalists, that everyone feels as though they can safely do the procedure. Our median time here across 5 different practitioners is about 20 minutes to vessel open. And that's arterial puncture, thrombectomy, vessel open, 20 minutes. But you have 5 neurointerventionalists who are all experienced, who do a very high volume. So we do about 250 to 300 thrombectomies a year across 4 or 5 practicing individuals. There are entire centers that don't treat 50 patients a year. Each one of our procedural physicians treats more than that. So unfortunately, the training curve is steep, and it's not something that can be easily done. Now, what are some of the options down the road? Teleproctoring, live proctoring, there may be solutions, but my biggest concern is if the message becomes anyone can do it, even if the intent was to make access available in geographic locales that are far from neurointerventionalists, the implementation may be that it happens in close areas. And I'll give an example. So in the United States, we generally had recognized primary stroke centers as offering intravenous thrombolysis, and comprehensive stroke centers offering thrombolysis, thrombectomy, neurosurgical expertise, everything. There was no middle classification. There are some areas where a middle classification or a thrombectomy capable center may be of use. So this is a center that can perform thrombectomy, but doesn't do everything that the comprehensive stroke center does. So the intent is good. The first 10 thrombectomy capable stroke centers all opened up across the street from comprehensive stroke centers for competition, not for patient access. So when we look at these types of tiered systems, and you can make the same argument regarding having a neurointerventionalist do your procedure, perhaps maybe having a vascular interventional radiologist who does not do a lot of cerebral work, but is facile with catheters. The intent is good, but it's all in the implementation, and a poor implementation may end up hurting a population more than helping. There's a couple more in the Q&A.
Okay, so in the Q&A, Dr. Vianney was asking, between MRI and CT, which is the best for diagnosis of
and I
stroke?
think we talked about that.
Yeah.
And
then the last one, some had strokes also has high risk to get it again. Is this, this is
I think that's a tougher question to answer, but there's a question at the top that says, in hospital, we don't have thrombectomy facility. What can be done if patient is out of window period for thrombolysis? So this comes up a lot. There are some centers that offer thrombolysis, but don't offer thrombectomy. So my answer to that is determine who is your closest center that you can transfer a patient to that does thrombectomy. Develop a protocol where you're obtaining a CTA as quickly as possible. So we work with our referring hospitals and teach them all, even though you're a primary stroke center, do the CT and the CTA right away. And if the CTA is positive for large vessel occlusion, work on transporting the patient. If they're thrombolysis eligible, great. If not, that's okay, but work on transferring the patient to the center that can offer thrombectomy. I see a question here about, do you do CTP routinely? If not, what criteria do you have in place? So I have a very strong bias about CTP, and we do not do CTP. And the reason that we don't do CTP is exactly the slide that I showed. I think that the core assessment is extremely unreliable, and regardless of a CTP-derived core, we are generally going to treat if the collateral score and the aspects are favorable. We're not going to withhold treatment. So in our opinion, at our center, it will not change. We are also biased because we have access to hyperacute MR. So we feel like if you need something above and beyond CT and CTA, we have the gold standard in MRI immediately available. So that is my bias. That is our bias at our center. The one value in CTP is in locations where you don't have neuroradiologists or radiologists immediately available to help interpret the scan. An abnormal CTP map can quickly tell you that there is some form of hemispheric blood flow abnormality. So if you're at a remote primary stroke center, the value in doing CTP may be to quickly alert the neurologists who are looking at that patient, quickly can say, yes, there's something going on. It may be a completed stroke, it may be salvageable, but there is something going on that is a hemispheric vascular event. And that is, to my mind, the one big advantage of doing CTP. But at centers where you have access to radiology expertise, I don't think it adds much. Daniel, I'm curious. I don't know. Do you guys still do it and look at it for fun?
The CTPs I've seen many CTPs, and in the lectures they come up pretty frequently.
Yep.
Yeah,
Yep.
They are a thing here for sure. I had another question. So
Yes.
time is brain, right?
Yep.
And you want to do a non-con and a CTA. Is there any moment in which you go straight into CTA and then use that same scan for the the pre-contrast?
Yeah. So if you could also do a virtual non-con out of the dual energy or something like that as a way of doing that.
Right.
We haven't. And the reason we haven't is we do the non-con sometimes even before they have IV access. You can get a non-contrast CT very quickly. You don't,
Right.
and remember, we're going straight from the ambulance to the scanner. We're not changing the patient. They're not in a hospital gown. We can do a non-con CT very, very quickly.
Mhm.
And if the non-con is negative, the TPA can be mixed. If the non-con shows a large bleed, we can immediately start thinking about therapy for the large hemorrhage. And so
Right.
we think that you do the non-con quickly, there's no bleed, there's no big stroke. You can actually start confirming TPA eligibility or ideally TNK eligibility. And then if there's a large hemorrhage, you have an answer. While we still do the CTA on the hemorrhage for other information, but at least it's a large hemorrhage. So we haven't done that yet.
Right. So we don't have any other questions. A couple more thank you messages from the audience. So yes, I think we can conclude the lecture. Dr. Jayaraman, thank you so much for this lecture. It was phenomenal to hear you speak and your takes on neurointerventional radiology.
Thank you so much.
Thank you so much, and we hope to have you again in the near future.
Take care.
Bye-bye.